છું એક જ મિનિટ લાગશે.
એકવાર આપણે કરી જોઈએ. તમારી બંધ કરો તો મારી આવી જશે જોઈ લેવા દો.
તમારી આવે છે
તમારું જ
સર,
અત્યારે
તમારું
ઉપર
ઓપન
છે
છે
સર.
ઓલરેડી. તમે
ના,
નેક્સ્ટ સ્લાઇડ.
મને મારામાં નથી આવતું ને યાર એટલે.
એ નહીં સર, તમે તમારામાં ઝૂમ ઓપન કરો સર. અત્યારે પીપીટી માંથી બેક જઈને ઝૂમ ઓપન કરશો ને, એટલે એ તમારી જ સ્ક્રીન અત્યારે શેર થઈ
હા,
ગઈ છે.
ઓકે ઓકે, ડન, મળી ગઈ.
હા, તો આપણે કરી તમારી બંધ કરો થાવ તો. હા,
તમારી આવે છે
તમારું
સર,
જ અત્યારે.
તમારું ઓપન છે ઓલરેડી. તમે
સર
નેક્સ્ટ
મને
સ્લાઇડ.
મારા નથી આવતું ને યાર એટલે.
એ નહીં સર, તમે તમારામાં ઝૂમ ઓપન કરો સર અત્યારે.
થઈ ગયું મારે આવે છે. ટાઈમિંગ કેટલું રાખવાનો છે કઈ?
1 hour સર છે ટાઈમિંગ.
તો
સો વી આર લાઈવ ઓન યુટ્યુબ નાઉ. સો good afternoon, respected doctors, for joining us on our sixth masterclass series of our banner called Medinsight. If I talk about Corona Remedies ranks 29th among top 30 pharmaceutical organization, which is growing at a 20% CAGR. We have our own manufacturing EU-GMP approved plant, and we have two separate manufacturing unit. Also, we are home to more than 4,500 employees, and we have more than 68 diversified portfolio. On behalf of whole Corona Remedies, I am very grateful and thankful to all of you for joining us on this masterclass series. Now, as per our Indian tradition, we initiate any auspicious occasion with lamp lightning. And as we are here today on virtual platform, so let us come forward for virtual lamp lightning followed by Ganesh Vandana.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
So it's my honor to introduce today's speaker, someone who truly needs no introduction in the field of internal medicine. He is Dr. Vipul Shah, and today's our session is on fever of unknown origin, mystery still unresolved. So I would like to give this podium to my colleague, Dr. Vishal. He will take you all and he will give a short brief about Dr. Vipul Shah, sir. So over to you, Vishal.
So, good afternoon, everyone. It's my honor to introduce our today's speaker, Dr. Vipul Shah. He is a leading infectious disease consultant in this field. He's also ex-assistant professor of medicine from 2000 2007 at BJ Medical at Ahmedabad. He received fellowship from Indian College of Physicians. He is a practicing as adult infectious disease consultant in Ahmedabad. He is a scientific committee chairman at Infectious Disease Society of Gujarat also. He has more than 25 publications in national and international journals. He is also author at the chapter in API textbook of medicine. He is a principal investigator in various clinical trials to the infectious disease, and he is also interested in FUO, HIV, TB, diagnostic of dilemma cases, and many more. So, sir, we welcome you for the today's session. So, I am now handing over the session to Dr. Vipul Shah. Sir, over to you. Thank you.
Thank you, Vishal, for the kind words. Uh, is the my presentation on screen?
Yes, sir. Your
Okay,
screen is visible now.
okay. Good afternoon, everyone. Uh, Today we are going to talk on the fever of unknown origin, solving the puzzles. So I'm not able to change the slides. Okay, fine. So William Musler said long back that three great enemies are fever, famine, and war. Of these, by far the greatest and by far the most terrible is fever. So we are going to talk today about the fever of unknown origin. So what is fever of unknown origin? In simplest way, it is a prolonged febrile illness without an established etiology, despite the evaluation and diagnostic testing. But if you want to define the fever of unknown origin, it was long back defined by Petrov and Bison in 1961 as a fever more than 101 degree temperature, Fahrenheit temperature on several occasions that remained for more than 3 weeks and no diagnosis despite 1 week of inpatient. So patient was admitted and workup was done, but still diagnosis was not bent. This is defined as a fever of unknown origin. But after 30 years of this definition, Durakan Street, because of the advancement in the technology, divided the fever of unknown origin in different groups. The classic fever of unknown origin, which is found in the immunocompetent patient, then the immunodeficient or neutropenic fever of unknown origin, nosocomial fever of unknown origin, and HIV-related fever of unknown origin. Today, we are going to talk about the classic fever of unknown origin. So what is classic fever of unknown origin in recent definition? So it is same 101 degree Fahrenheit for more than different occasions. Duration is more than 3 weeks. But the third one is changed from 1 week of inpatient investigation to the evaluation of 3 weeks as an outpatient clinic or 3 days in hospital or 1 week of intelligent and invasive ambulatory investigation. In nutshell, because of the advancement of technology and the various tests, this definition has little bit changed to if you are do a very important intelligent and invasive investigation, still diagnosis is not made, then it is defined as a fever of unknown origin. So which are these investigations? So it's a CBC, complete blood count, ESR, CRP, the chemistry in the form of electrolytes, liver function, kidney function, LDH, CPK, ANA, R factor, routine micro, and the cultures, blood cultures, and X-ray and ultrasonography. So these are the investigations which is required. If they are normal or not contributed to any diagnosis, then it is defined as a fever of unknown origin. So let's better understand by case. Here is a 48 years old businessman from Ahmedabad who was in regular follow-up with the GI physician for chronic alcoholic liver disease since 1 year, admitted in a hospital under the physician for fever and weight loss in May 2023. He was evaluated extensively. Her hemoglobin was 11.1, ESR was 90, CRP was 3 times of upper limit, that is 15.8, and his routine health check profile shown routine normal routine micro, PSA, alpha fetoprotein, lipid profile, TSH, B12, D3. So in nutshell, the overall investigation was normal. He was negative for the serology for the hepatitis B virus, C virus, and HIV. Normal X-ray chest. These are basically her tests. In 2022, when he was diagnosed first time as a chronic alcoholic liver disease, her GGT was high and the enzymes were deranged. Bilirubin was also high. But at this point of time, he stopped taking alcohol and gradually her liver function has improved and it came to normal in January 2023. And in May 2023, when he had a fever and weight loss, it was almost completely normal except for the protein AG ratio, which was altered. He underwent a CT scan abdomen, which shows various liver lesions along with the liver cirrhosis, which are diagnosed in the form of cholangiocarcinoma. The CT scan or radiologist put the possibility of cholangiocarcinoma with multiple nodes in the periportal, hepatogastric, and upper and mid periodic region. So these are the lesions. Basically, these are the multiple liver lesions. One of them is here, which was showing or suggestive of cholangiocarcinoma by radiologist. So liver was involved along with the fever and weight loss. So GI physician tried to take a liver biopsy from that lesion, which has shown scanty granulomatous inflammation, but there is no evidence of any malignancy. And microbiologically, obviously, because they were not suspecting any infection, they didn't did any gene expert AB culture, fungal culture, or pyogenic culture, but only biopsy was done, which suggests of scanty granulomatous inflammation. Then they tried to do some other test to get a diagnosis. So there were multiple intra-abdominal nodes were there. So GI physician tried to do a endoscopic ultrasound guided abdominal lymph node biopsy. And the lymph node biopsy, here they did a gene expert test for tuberculosis, which was negative. And obviously they did also histopathology along with this. But again, histopathology was inconclusive because it suggests you have only reactive nodes. So in two biopsies were done, one from the liver, one from the nodes. Again, in some liver lesions, there were no microbiological workup done, while here, these are, both are negative. So now what next? Two biopsies were done, still fever, weight loss. In a case of liver lesions, it is a mystery. So he came to us, rather he referred to us by GI physician to start empirical anti-tuberculosis treatment. But we know that patient is a already known case of chronic alcoholic liver disease, and to start empirically any anti-tuberculosis treatment in such a scenario, if the patient develops any hepatic dysfunction, patient may be go in a very bad shape. So here the patient has a 25 days of fever, maximum of 101 degree temperature, daily 1 or 2 spike without rigors any time of the day. He had a 10 kg weight loss in last 3 months. He had anorexia, mild upper abdominal pain. Rest of the other symptoms were not present. Further, her past history suggests to hypertension for what he was in on the telmisartan. He was hypothyroidism, having taking 100 micrograms thyroxine per day. He is a known case of chronic liver disease. Personal history, he was alcoholic and stopped since 1 year. He was a tobacco chewer. Family history was not significant. So on examination, absolutely normal, except what we find on general examination, that the bilateral axillary lymph nodes were enlarged. So here is again a clue that in fever case of fever of unknown origin, when you are taking a detailed history, also do a detailed examination. Always look for the cervical as well as axillary lymph nodes, because we are going so many fancy investigations like in the form of CT scan abdomen, endoscopic ultrasound guided biopsies, liver biopsy, but we are not looking at the normal general examination findings, which here shows bilateral axillary lymph nodes enlarged. So it is a very easily accessible and important findings on clinical examination. Rest of his systemic examination was normal. So here, potential diagnostic clues for fever of unknown origin in this patient were weight loss, lymphadenopathy, and liver lesions. Now we have to choose from these to get a diagnosis. So what is potential diagnostic clues? Let's understand a little bit in detail. So potential diagnostic clues are defined as a localizing signs, symptoms, or any abnormality in an investigation, either in the form of laboratory or radiology, potentially indicating a certain diagnosis. So always in a case of fever of unknown origin, try to find out the potential diagnostic clues. Either you take a detailed history and you will get some clues from the history. You do a detailed examination, you get PDC from the examination, or whatever the investigation patient has already previously done, and what you have done, you find out just the important abnormal results, and from these PDCs you can reach to the diagnosis. So always search for the PDCs in a case of fever of unknown origin. So here we did further workup at our places. His complete blood count was normal, ESR was raised, the LDH was normal, the brucella serology we carried out was negative. The ACE level we did for the sarcoid because he had a liver lesions, lymphadenopathy, fever. So all these are differential diagnoses: brucellosis, sarcoidosis, lymphoma. So we did started workup from the some lab investigation. The Epstein-Barr virus panel was done, which was suggestive of past exposure, so no acute infection. We asked for the USG neck and axilla, and here you can find out that there are multiple lymph nodes in both axilla. The largest was 21 by 11 millimeter, and definitely they have a query lymphoma, query infective etiology. So it is a very easily accessible. So next step was we get a biopsy from the axillary lymph node. So we did a excision biopsy from the lymph node. It was diagnostic. So here the gene expert came positive, the MTB detected, and it was trace resistance was indeterminate. So it is a clear-cut case of, and if you look at the histopathology of this lymph node, there is extensive caseation necrosis with granuloma. So it is confirmed case of tuberculosis. So here the final diagnosis in this case of fever of unknown origin was extrapulmonary tuberculosis involving lymph nodes and liver. So classic fever of unknown origin, what are the important causes for this? The one group is infection. Here the extrapulmonary tuberculosis remains the leading diagnosable cause of fever of unknown origin, particularly in India. The second group is malignancy. Various malignancies can cause fever of unknown origin. Various non-infectious inflammatory diseases like autoimmune disease can cause fever of unknown origin. Certain miscellaneous causes are there, and still, even after extensive evaluation, we may sometimes remain undiagnosed with fever of unknown origin. So this is another. Lastly, when you do a complete workup, still diagnosis is not made. It is known as an undiagnosed fever of unknown origin. So this is basically if you look at the studies carried out for fever of unknown origin to find out the cause or etiology from 1961 to 2019, various authors tried to find out what is the current trends in causes of fever of unknown origin. Still, infection is the leading cause of etiology for fever of unknown origin. Second is malignancy, then the inflammatory cause, miscellaneous and undiagnosed. In some of the series, even 50% of patients they remain undiagnosed, varying from the 7% to 51%. So infection, if you look at the Indian scenario, we had a 10 days, 10 years interval studies. I had taken 3 studies, 2001, 2011, and 2021. Still, infection is the leading cause of almost 50% of the fever of unknown origin. They turn out to be a infection as a cause. The rest of them are neoplastic or malignancy, the non-infectious inflammatory disease condition, or miscellaneous. And around 15%, they still remain undiagnosed. So what are the causes of infections? They can turn out to be a etiology for the fever of unknown origin. So tuberculosis in India remain the chief cause. The extrapulmonary, you have to find out the various sites to look at for the tuberculosis. Certain intra-abdominal abscesses, which are very small and easily missed by sonography, pelvic abscesses, dental abscesses, endocarditis is a very important group of condition where the fever of unknown origin is important. Osteomyelitis, sinusitis, certain viruses like cytomegalovirus, EBV virus, Lyme's, prostatitis. So these are the group of conditions or the organism which can lead to the fever of unknown origin. Let's go for the another case. So we can understand better in by case rather than a theoretical. So here is a 67 years old female who had 30 days of fever, daily 2 spike without rigors, maximum 101.6 degree Fahrenheit. So it is classical of 1 month duration of fever, and there is a considerable symptoms in the form of anorexia, body ache, and weight loss. No other symptoms, significant history. If you look at the travel history, if you look at the history of pet exposure at the home, if you look at the sexual history, occupational history, everything was normal except 67 years old female having 30 days of fever and body ache, anorexia, nothing else. Even his past history was, her past history was significant in the form of hypothyroidism, 7 years, taking thyroxine 100 microgram per day. She was type 2 diabetic, taking oral hypoglycemic agents. Rest of his past history, personal history, and family history was not significant. On examination, vitals were normal, only pallor were present. On general examination, no icterus, clubbing, cervical, axillary lymph nodes, edema, or skin lesions. Oral cavity was normal. Cystic examination was also normal. So what we have looked into the previous investigation, because she was having a 1 month fever. She was remained with the physician, investigated thrice. So what we had in the previous investigations, his hemoglobin was low, 10.3 gram percent. ESR was raised. Counts with differential count and platelet count was normal. Urine routine was normal. Sugar was in normal. RBS was 133. Her liver enzymes were normal. Create was normal. CRP, she underwent 3 times. So from 43, it went to the 61, and ultimately, when she came to us, it was 93. Dengue serology was done by physician, was negative. Vidal test was done, was negative. She also been tested for the Mantus, and it was positive by 22 by 18 millimeter. So basically, she also underwent a X-ray chest, which was normal, and ultrasound abdomen, which was grade 1 fatty liver, and incidental findings of angiomyolipoma of lower pole of kidney, which was not at all contributed to the fever. So she underwent routine laboratory investigation, including X-ray and USG, which was normal. And when she referred to us, again referred to us because her Mantoux test was positive and he had a fever of one origin. So to start antituberculous treatment, again the same scenario as last case. But here on examination history, there was no PDC except the fever of one origin and constitutional symptoms. Mantoux test was positive. That was the only PDC which we never do Mantoux test for diagnosis of tuberculosis. So for us, it was useless. So what we did blood cultures, which are mandatory to rule out the causes. So we sent 3 sets of blood cultures, which was negative. We did thyroid function, normal. We did brucella serology, which is an important infective cause for fever of unknown origin, which was negative. We did a antinuclear antibody because she was elderly female and having a fever of unknown origin, no clue. So ANA was negative. She underwent 2D echo to rule out endocarditis, which was normal. She underwent ultrasound for necks, axilla. There were bilateral sub-centimeter size reactive lymph nodes, non contributed to our diagnostic test. She underwent CT scan abdomen and thorax with contrast enhancement, which was also normal. So again, what we did a routine test for the fever of unknown origin as a part of workup, which turned out to be a negative. So now what next for this patient, as there is no PDC? So how will you solve the puzzle? So we did a PET scan, whole body FDG PET scan. The arrow shows aorta, and it has shown a aortic abdominal aorta showed enhancement or FDG uptake. Again, here you can see very clearly the aorta taking uptake. So FDG PET scan gave us a diagnosis. So it was a hypermetabolic asymmetrical circumferential wall thickening without liminal narrowing, involving arch of aorta, root of left subclavian artery, thoracic and aorta till bifurcation, which was suggestive of large vessel vascularitis. So here everything was normal, including CT scan, ultrasound, blood test, and whatever you did, a history examination was normal, but only PET scan gave you a diagnosis for this fever of unknown origin. So it was a large vessel vascularitis, and this vascularitis cannot be picked up by the routine CT scan or MRI. So this is a non-infectious inflammatory conditions which can present as a fever of unknown origin. So these are some of the non-infectious inflammatory diseases which can present you as a fever of unknown origin. The Still disease or AOSD or adult onset Still disease, we see usually every month one patient of adult onset Still disease as a part of fever of unknown origin. Polymyalgia rheumatica, temporal arthritis, particularly in elderly patients, rheumatoid arthritis, inflammatory bowel disease, especially Crohn's disease, Ritter syndrome, SLE, antiphospholipid antibody syndrome, certain vasculitis, sarcoidosis, granulomatous hepatitis, and Kikuchi's disease. These are the some of the non-infectious inflammatory common conditions which can present as a fever of unknown origin. So not always fever is equal to infection. Particularly, you have to keep in mind. So usually for first week, you may give some empirical antibiotics according to your judgment or the presentation. But once 1 week is over and patients still running fever, try to get a diagnosis, and then start appropriate antibiotic. So all the fevers are not infections, non-infectious conditions, including the inflammatory disease as well as malignancy, can present as a fever of unknown origin. So, what is the role of FDG whole body PET-CT in case of fever of unknown origin? There is a growing volume of evidence that this FDG PET can be an important nuclear medicine test of choice in case of fever of unknown origin. If you look at the sensitivity is almost 94.7%. Specificity is 50%. So it is not specific, so much specific, but definitely sensitive test to give you some clue regarding your diagnostic possibilities. The positive predictive value is again very high. So PET scan can give you a three important information. It can sometimes give you a directly the cause of fever, like in this case, having a large vessel vasculitis. It may sometimes not give you directly cause of fever, but may localize the site for further evaluation. Example, somebody is having a multiple nodes in the abdomen, mediastinum, neck, and axilla. You did a one biopsy which was negative. Now what next? So PET scan there will help. Not all the nodes, lymph nodes which are shown on the CT scan or ultrasound are pathological, and you get a biopsy and you will get a diagnosis. But if you do a PET scan, then those lymph nodes which can take a uptake, high uptake, and if you biopsy that lymph nodes, you will definitely get a biopsy. So it may help in the localizing the site of evaluation. Sometimes simple osteomyelitis is there which was not picked up because patient is just having a young male having a pain in the right thigh. You do a ultrasound, you do a scan which may miss the infection or in the case of osteomyelitis. But if you do a PET scan, it will definitely take up early in the phase, and you just do a biopsy, you can confirm the diagnosis. And lastly, a negative result exclude the focal disease as the cause of fever. There are limitations of CT scan, MRI, and ultrasound. Which are these limitations? The inflammatory and infectious lesions can remain undetected as substantial anatomical changes take time to develop, which may be absent in the early phase. What it means to say, their CT scan, MRI will take up the diagnosis when it is full blown or when the anatomical changes has been established, while the PET scan pick up this diagnosis before even the anatomical changes can take place. So this is the advantage. Secondly, distinction between the active foci and the residual changes due to cured process of surgery is a limitation. So just give you an example. Somebody is having underwent some cesarean section for his delivery, and then later on have a fever, and there is a doubtful inflammation. So in this case, CT scan sometimes give you a findings that it is a post-operative changes or residual changes. So it is very difficult to pick up from them CT scan that there is a really active infection or residual changes. But PET scan can help whether it is an active infection or it's a residual changes. And lastly, these imaging techniques routinely provide information only on a part of the body. So if you do a CT thorax, it will give you information regarding the thorax, not about the abdomen or neck or even limbs. While the PET scan give you information from the all parts of the body. So these are the advantage of PET CT over the CT MRI in US in case of fever of unknown origin. Let's understand other things by case 3. He is 36 years old male from Idar, Gujarat. He had a fever since last 30 days, almost 1 month fever, daily 2 to 3 spikes per day, maximum 103 degree Fahrenheit without rigors and associated with the body ache and headache. He had a dry cough since last 9 days. He had a left upper abdominal pain since last 9 days, almost continuous, mild, dull aching type without any relation to meal or movement. He had anorexia. He had a loss of weight around 4 kg in last 1 month. And look at the antibiotics. He received cefixime, levofloxacin, and OPD basis, and ceftriaxone during hospitalization for 5 days without any significant improvement. So he underwent 3 courses of antibiotics with 1 month fever, cough, left upper abdominal pain, and weight loss and anorexia. Further, he had no history of any recent travel except the routine field visit to the nearby villages, but there is no animal exposure. No significant past or personal history. father is diabetic and mother had a renal stone disease in the family history. His temperature was normal. Pulse was little bit tachycardic in the form of 114 per minute. Rest of his vitals were normal. On general examination, anemia was present. Rest of the things were normal. Liver and spleen both enlarged, and there was tenderness in the left hypochondric region. Rest of the systemic examination was normal. Now, again, before coming to us, he underwent some investigations during hospitalization and OPD visits. That is from 3rd April 2022 to 1st May. So he was little bit anemic, 11.3 gram percent. Platelet count was borderline low, 1.48 lakh per cubic millimeter. ESR was raised, 54. Urine routine was normal. Vidal test, which was done weekly, positive. Again, similarly to a Mantoux test, Vidal test, if done once, is a useless test. Please don't do this for the diagnosis of enteric fever. Rather than a blood cultures is a very valuable test for the diagnosis of enteric fever. His sugar was normal, liver enzymes were normal, create was normal, CRP was raised, TSH was normal, and dengue serology was negative. So these are his previous investigations. He also underwent ultrasound, which was suggestive of mild enlargement of spleen with sub-centimeter size hypoechoic lesions in the spleen, and that was diagnosed as a query infarct. Rest of the things were normal. At our clinic, we also did investigations. Again, similarly, mild anemia, lymphocyte predominant, but normal leukocytes count. Platelet was borderline low. Here we have a deranged liver function test. Bilirubin was normal, but SGPT was 144, SGOT was 124, alkaline phosphatase was 160. Create was normal. We did a Brucella antibody titer, which was turned out to be a positive. Now again, here is another important infectious cause as a fever of unknown origin. We initially thought that the Brucella usually comes positive in case of those who are remaining in the villages. Basically, Brucella occurs in those patients who have who are consuming unpasteurized milk or milk products. So we thought that this is usually a disease of rural population. But nowadays we are seeing Brucella also in case of urban population, those who are consuming raw milk or raw milk products. So here we have a Brucella. We do usually those who have a history of field visit or those who have a history of unpasteurized milk. We usually do a Brucella antibody test in a routine workup for fever of unknown origin. And here it turned out to be a positive. We also asked for the blood cultures, which was report was awaited. We asked for the CT scan because we are also worried about because see, Brucella antibody is a basically antibody test. It doesn't give you information regarding the Brucella organism, which usually found to be 100% confirmatory on blood culture or bone marrow culture. So blood culture was awaited. So meanwhile, we also look at the splenic lesions where it can be a cause of a fever. So we asked for the CT scan abdomen. Here there was a multiple splenic infarcts were there, single prominent dry petechial lymph nodes, and mild hepatosplenomegaly. So it was confirmed that these are the infarcts. So splenic infarcts when comes in any CT scan, we always look at from where it has been the emboli came and block the vessels. So we always, in case of splenic infarct, do a 2D echo, and we did a 2D echo in this patient again as a part of workup also, as well as when there is patient having splenic infarcts, it was suggestive of endocarditis. So there was a vegetation over the anterior mitral valve leaflets. So this is the case of endocarditis with splenic infarct, and here the Brucella antibody was positive. So we are now in dilemma whether this Brucella antibody to be addressed as a cause of fever of unknown origin, or we have to look at the other causes which can cause endocarditis and splenic infarct. So we waited for the blood culture, and the blood culture turned out to be a positive. So look at this, both the blood cultures, it was suggestive of Brucella melitensis. So it was the Brucella which was causing endocarditis and splenic infarct as a part of unknown fever of unknown origin. So what should be the informed to microbiologist while sending a suspected Brucella in blood culture? So this is very important point. I just want to highlight. When you are suspecting Brucella as a cause of fever of unknown origin, took the blood culture in the same bottle like aerobic, ask your microbiologist that incubate this blood culture for 3 weeks minimum. Because what happens that usually Brucella comes positive or Brucella grew in the blood usually by after 5 days. So most of the laboratories, they do blood culture, they give negative reports at the end of 5th day and they discard the bottle from the machine. But when you are suspecting Brucella, if you ask them to put this bottle for 3 weeks in the incubator or machine, then definitely you will get a positive Brucella in the blood. Otherwise, you will never get blood culture positive for the Brucella. So here it was a clear-cut case of Brucella endocarditis leading to splenic infarct, which was a cause of fever of unknown origin. Let's see another case. This is my last case. Then I will just look at give you some guidance regarding how you can proceed in case of, also how will you approach to case of fever of unknown origin. So here is a 59 years old businessman from Ahmedabad. He admitted for 1 week from 8th July to 14th July under care of oncophysician for 3 days of fever and thrombocytopenia. So why he went to the oncophysician? Because initially he was seen by a physician. He worked up as a part of thrombocytopenia and there was no clue. So he asked the oncophysician to take this case over, and if there is an infection, then they definitely he will guide. So he underwent various tests. He underwent a USG abdomen where there was multiple small hypoechoic lesions in the spleen. Again, evaluated in a hospital and OPD base. His bone marrow biopsy was done to find out the cause for thrombocytopenia, because all the possible cause of thrombocytopenia in a case of fever like dengue, malaria, scrub typhus, this was done, which was negative. So he underwent bone marrow because oncophysician want to do it. It was turned out to be a normal. He also underwent a bone marrow test for the microbiological test like gene expert and AB culture. AB culture report was pending and gene expert was negative. He was put on a antituberculous treatment again. Because why he was put on an antituberculous treatment? Because he had a small hypoechoic multiple lesions in the spleen. Now multiple small hypoechoic lesion in the spleen, which we usually say it is a splenic infiltration. The splenic infiltration, again, the common causes are tuberculosis, sarcoidosis, rosacea, lymphoma, histoplasmosis. So these are the usual causes. So they put a patient on an empirical antituberculous treatment by a physician because of the splenic lesion, as well as some of the findings on the HRCT thorax. There were multiple lymph nodes were there. So symptoms plus findings, they put an antitubercular treatment, but patient stopped after 10 days as it was not tolerated. Fever persisted since then, but platelets came to normal. So surprisingly, without treatment, these platelets came to normal, but fever persisted. So there are multiple. He also underwent CT scan of abdomen and pelvis in the next visit, which turned out to be a normal. So splenic infiltration, which was shown on an ultrasound, which may be a misleading, or it may be a missed some maybe a false positive findings, which was on a CT scan, should be obvious, was normal. So again, he also came to our clinic for this is fever of unknown origin in the form of almost 3 weeks were again. Fever persisted, platelet came to normal. He had also some daily 1 or 2 spike of fever up to 102-degree temperature with chills, associated body ache, weight loss of 8 kg, anorexia, and no other symptoms. Again, pure case of fever of unknown origin. So his past history, in February 2023, he underwent coronary angiography and PTCA to LAD because he developed non-ST elevation MI in Feb. He is diabetic since February 2020. At that time, he was also diagnosed with diabetes. In June 2023, he underwent lap cholecystectomy plus pus drainage for acute calculus cholecystitis and biliary pancreatitis. And from this June 2023, he started having a later on fever. Personal history and family history was not significant. He was on a various antiplatelets and the statins and the anti-diabetic agents. On examination, vitals were normal. pallor was present, and spleen just palpable. Rest of the systemic examination again was normal. So in summary, diabetic, hypertensive, past PTCS, stented patient, recently operated for cholecystectomy, fever, weight loss and anorexia, anemic, transient thrombocytopenia which was recovered, and mediastinal lymph node with fibrocalcific lesion in the right upper lobe on the CT scan. So these are the only potential diagnostic clues. So what is the differential diagnosis? So when a patient comes for fever of unknown origin to us, we from his history examination and the positive findings make some differential diagnostic list. So here it may be infective in the form of tuberculosis or brucellosis, or maybe some residual intraabdominal infection because he underwent a cholecystectomy and pus drainage. It may be a sarcoidosis in the case of non-infectious inflammatory disease because it's a splenic infiltration, lymph nodes, fever, and weight loss. It may be neoplastic like lymphoma because again lymph nodes, splenic infiltration, fever, weight loss, or it may be miscellaneous, some other cause as a part of drug fever because multiple drugs were patient was taking for his diabetes, hypertension, IHD, and post-surgical status. So on 31st July, we did some investigation at our place. Here, patient was anemic and ESR was raised. Count were absolutely normal. His liver enzymes were deranged. His SGPT, SGOT was raised. Alkaline phosphatase was also raised, and GGT was raised. Urine routine was normal. Create was normal. CPK total was normal. LDH was little bit high. ACE level we did for the sarcoidosis, which was turned out to be normal. Thyroid function test we did a TSH, so 0.3, little bit low. Brucella serology was negative. We did a 2D echo, which was suggestive of little bit mild LV dysfunction because of his history of ischemic heart disease. We did for the USG neck, axilla, and groin. Again, there are thyroid nodules were there, and some lymph nodes were there, but it was not so much large size. It is around 10 into 8 millimeter. So we usually by and large less than 1.5 centimeter or 15 millimeter size lymph nodes. We usually consider it to be a non-pathological nodes, and we don't do a biopsy from that. Again, CT scan thorax we did repeated, and they wrote that as compared to previous scan, there is no significant interval changes. So again, lymph nodes were still there. There is no improvement, no deterioration. So we advise endoscopic procedure in the form of endoscopic ultrasound guided lymph node biopsy. Patient refused for that. We asked for the PET CT. Again, patient refused because during this time of workup at our place, he became afebrile. So he was febrile for few days, again afebrile, then remained febrile, came to us. While we are working for this diagnosis, he became afebrile. So as usual, when the patient became afebrile and for which he came to us, he refused for the PET CT also. Me and the patient both were not in the plan to start antituberculous treatment without any evidence as we do. So we asked that you go home, just have a routine, monitor your temperature and come back to us if there is a again fever. So he again became febrile with more intensity of fever in few days, and he came back us. And this time he agreed to a PET CT. So what we did PET CT, and PET CT revealed multiple small to mildly enlarged FDG avoid nodes at supra and diaphragmatic regions. Is a multiple hypermutable lesion involving the vertebra. So what we are not able to see in the CT scan or any like CT scan also shows some vertebra, but here the vertebra, sternum, bilateral ribs, right scapula, sacrum, pelvic bones. So there are multiple skeletal involved as well as the nodes were there, and they put a possibility of lymphomatous infiltration. So this is PET CT. So we asked for the biopsy, and we did a biopsy from the nodes, and the gene expert came negative for the MTB. While we asked for the histopathologic examination, the ISC, and ISC and histopathology examination, they give final diagnosis of classical Hodgkin's lymphoma. So again, in a case of fever of unknown origin, where it started from thrombocytopenia, which recovered, became febrile, afebrile, febrile, afebrile. So this is again a important insight. Now the Pal absent fever where the fever comes high grade, remain for few days, again become afebrile, again fever high grade, become afebrile. So this is what is known as a palestine fever. You always look into the lymphoma. So which are the malignancies which can cause fever of unknown origin? Lymphoma is in the topmost. Metastatic cancers, renal cell carcinoma, chronic leukemia, multiple myeloma, certain solid tumors like breast tumor, breast carcinoma, liver, colon, and pancreatic cancers can cause fever of unknown origin. Myelodysplastic syndrome can cause fever of unknown origin. Sarcomas and atrial myxoma. So these are the three important groups I discussed: the infection, the non-infectious inflammatory conditions, and the malignancies. Now, important miscellaneous causes which can present to you as a fever of unknown origin. The drug fever. So, whenever you are taking a history, take detailed history of not only the allopathic medications, but also the herbal medications, non-allopathic, herbal, homeopathic, Ayurvedic medications. So, always look into the drugs which can cause fever. Thyroid is an important cause of fever of origin. We get 2 or 3 patients per month of thyroiditis as a presentation of fever of origin. Crohn's disease, embolism, this can cause also fever of origin. So how will you? So these are my 4 important cases which will also you highlight the important causes or group of disease which can cause fever of origin. Now, last few slides regarding approach to the patient with fever of origin. So once patient is diagnosed to have a fever of origin, how we should approach? It is the diagnosis of febrile illness that the science and the art of medicine comes together. Good and extensive history, including the sexual history, occupational history, travel history, drug history, allergy history, and so detailed you have to go for to find out the any clues or PDC. Thorough physical examination, including the vitals, clubbing, lymphadenopathy, edema, your oral cavities, the skin lesions, because you have to ask the patient to open the shirts and pants both. You have to look at the some skin lesions which can give you a clue for the fever of unknown origin. Checking all the previous reports and medications, evaluation of cultures, special tests, and the re-examination of tissue. This will give you the final diagnosis. So these are the important, just to highlight the travel history, exposure to pets and animals. So what I described, these are the important things to ask in the history. These are the important things to be seen in a examination. Some have to look at the temporal artery tenderness, some rashes, anterior neck tenderness for the thyroid, murmur for the diagnosis of endocarditis. So based on the PDCs, make a limited list of probable diagnosis, and from that probable diagnosis, try to get some other tests, and finally you get a some help of FDG PET CT can be taken if you are not come to the conclusion for the diagnosis. So these are the last 2 slides which you give a stepwise approach. Perform a comprehensive history and complete physical examination. Is there any PDC identified? If yes, according to PDC, get some invasive or non-invasive test. If there is no PDC, then do a step 3 in the form of obligatory investigation, including the complete blood count, ESR, CRP, biochemistry, HIV serology, cultures of the blood, urine, ultrasound, CT scan, abdomen, pelvis, and if required, echocardiography. If you are getting diagnosis from this first tier testing, yes, then complete the diagnosis, or you may require some further tests like MRI, PET CT, and ultimately histology or microbiology, do a diagnosis. If even after first tier testing, still you are not having any PDC conclusion, then go for any, again you have to take the detailed history in a second sitting. There is there any PDCs there? Yes, then do an appropriate test. If still not any PDC, finally you have to do a PET CT, if not done previously. So this is the final, after 2 times evaluation. If you're not able to do a diagnosis, do a PET CT. If there is a positive result, apply the appropriate invasive and non-invasive diagnostic studies to confirm the diagnosis and the etiology. Still, after even PET CT, if PET CT is normal and the patient is running fever, so it means there is a negative PET CT. You have to look, ask the patient, give reassurance that there is no major disease. You just go home, just monitor your temperature and come back again when you have some other symptoms, or at least ask patient to have a every week follow up to get some any positive findings in the form of symptomatology, new symptomatology, new science, or new tests. Still, even after doing all these things, certain amount of patients they remain still undiagnosed in the case of fever of 1 that we have to accept it. So this is my nutshell presentation on the fever of unknown origin. I hope that you will have some learning points from this presentation, and thank you.
Thank you so much, sir, for this wonderful session. So it will surely help all the healthcare practitioners in their day-to-day practice for the identification of the fever from the unknown origin. So here we are ending the session. So before that, I want to thank Dr. Vipul Shah for this session, our today's speaker, and all the healthcare practitioners for joining us today for the digital masterclass series, which is Medinsights. So, with a wonderful response, I am sharing we are organizing one more sessions few days after. A session details, the timings, and the speaker note will be shared with all the healthcare practitioners shortly. So, till then, thank you very much and see you soon. Thank you, sir, for this session.
Thank you.
Thank you, sir.